Okay, so today we will be talking about the sympathetic blocks, or what we call it as the autonomic blocks also as well, especially for the visceral pains. And if you see this diagram from top to bottom, there are many ganglions. Okay, so which includes sympathetic as well as parasympathetic ganglions. Okay, so sphenopalatine is one of the parasympathetic ganglion, but rest of the ganglions like the celiac plexus, you can see my cursor moving on that. You can see my cursor.
Yes, sir.
So that's a celiac ganglion, okay, which we usually block it for certain indications. We will go into that. Then our superior hypogastric plexus, it is another sympathetic plexus. Okay, then we inferior hypogastric, which we usually don't perform, and then at the last is the ganglionepar. So these are the commonest things which we perform, and we also do our stellate ganglion, which is somewhere over here. Inferior cervical ganglion and middle cervical ganglion, they usually form a stellate ganglion. Okay, sphenopalatine ganglion is very not a very commonly performed thing, but it is a block which is usually performed for facial pains when nothing works. So that is how I look when performing that block. Okay. So we have to perform blocks always based on the anatomical site of the lesion or the injury. It's not that the patient is having an abdominal pain and you will say, abdominal pain, we can also do a superior hypogastric plexus block. But we have to see the exact anatomical lesion, and accordingly you have to chart your pain. When the patient gives you pain descriptors, you have to chart the pain on the body diagram, and accordingly you know, okay, this is the dermatomal distribution, or this is your pain anatomical site, and accordingly you can perform the block. That is how we usually perform the block. Okay. So if you see this boxes, is a very schematically made boxes, and if you see based on the site of the lesion, the potential sympathetic blocks which we can perform. So a sphenopalatine block, nasal mucosa, palate, tongue. So anything which pain which originates from this particular sites, we can easily perform, or the potential sympathetic block to perform is a sphenopalatine. But as I already said, that you can also perform sphenopalatine. I usually perform sphenopalatine when everything fails for the facial pain. Okay, but specifically the indication I usually perform a sphenopalatine block is the nasal pain. So the tip of the nose pain the patient has, particularly in that area, I usually perform a sphenopalatine block for that particular indication. And other the indication I already told you. Then stellate ganglion block, you can see, if you are seeing, it matches with the eye, parotid, thyroid box as well as the upper extremity box. So upper extremity as well as these parts, the stellate ganglion block can be used. And again, you have to understand the stellate ganglion block, the peculiarity of the stellate ganglion block is that middle cervical ganglion, inferior cervical ganglion, as well as the thoracic component, sympathetic chain, T1 especially, as well as sometimes T2 is involved in formation of this stellate ganglion. So there is a saying in our pain practice that if you want to, the pain which originates from the face, then you do at C6 level, and if the pain originates from your upper limb, you do it at C7. That is what is the saying, and that is how it is usually practiced. But what I had seen in my practice is that whether you give it at C6 or at C7, because the volume of injectate which you give, the spread is so high, so that it sometimes goes up to C5 and it goes down to T2. So it doesn't matter whether you're giving it at C6 or C7, this particular block. Stellate ganglion. Thoracic sympathetic, yes, upper extremities as well as mediastinal and trachea. We usually don't do for this at all. Only for upper extremities, I usually do a upper thoracic sympathetic blocks. Then the most common, the celiac plexus or the splanchnic nerve blocks. Anything, the pain originating from the distal esophagus, stomach, gallbladder, liver, pancreas, small intestine, entire small intestine, and large intestine up to the splenic fixture. So this is very, very important, up to splenic fixture. After that, your superior hypogastric plexus takes over. You see that large intestine from splenic flexure. Okay. Upper ureter and kidneys. Even if there is an adrenals, you can still perform a celiac plexus or a splanchnic nerve block. We will come to that when to do celiac plexus, when to do splanchnic nerves. It is again to your comfort, as well as there are certain particular conditions where you can do that and certain indications. Now, so lumbar sympathetic, I'm not going to touch. Sada has already talked about this extensively. Then superior hypogastric plexus, what we usually perform is a lower abdominal. Very crudely, if you ask me, upper abdominal, celiac plexus, lower abdominal has superior hypogastric plexus, and perineal pain, ganglionic part. That's it. So this is how you remember. A very easy way. Upper abdominal रहेगा, तो भाई celiac plexus लगाना है. But at the same time, scientifically, you have to remember up to splenic flexure, pain originating from any organs up to splenic flexure, including liver, kidneys, adrenals, okay, gallbladder. Yes, you have to do a celiac plexus. And after that, if it is away from that, from the splenic flexure, there's a large intestine, lower ureter, uterus, even the proximal vagina, you can do a superior hypogastric plexus. And perianal region. So perianal region or perineal region, we call it as. So perineal region includes the vulva as well as your anal opening. So that area, entire perineum area, you can do a ganglionic block. I think I made this point very clear. Okay. All right. So coming to the celiac plexus. So now if you see the celiac plexus, it is formed by splanchnic nerves. Okay. So there is something called as a greater splanchnic nerve. There is something called as a lesser splanchnic nerve, and there is something called as a least splanchnic nerve. So these are the preganglionic nerves which arise from T5 to T9. Okay. And there is a greater splanchnic nerve, and at the level of T9, they coalesce to form the greater splanchnic nerve. Okay. And they end into a plexus that is called as a celiac plexus, which is situated at the celiac trunk of the abdominal aorta. I will show you a diagram. Okay. Then the sympathetic nerves which are coming from T10 to T11, they are called as a lesser splanchnic nerve. So you just remember the root value, lesser splanchnic nerve, T10 to T11, because in exams we may ask you. And T12, a least splanchnic nerve. So these three group of nerves, they coalesce at the celiac trunk and form a plexus that is called as, or a ganglion, which is called as a celiac ganglion or a celiac plexus. So this is what I wanted to make you understand. So these are your sympathetic ganglions, okay, which was earlier covered in your last talk. Okay, so they give these preganglionic nerve fibers, okay, and they coalesce from T5, okay, to T9, and they form the greater splanchnic nerve, and T10, T11, they coalesce to form the T10 to T11, they form the lesser splanchnic nerve, and T12, this is the least splanchnic nerve. So you can see the least splanchnic nerve, okay, the lesser splanchnic nerve, and the greater splanchnic nerve. All these three, they go and coalesce with the celiac ganglion. And the celiac ganglion is not a smaller thing. It is a huge semilunar shaped ganglion, which is situated on both sides of the abdominal aorta, almost around, it's a huge thing. It's a visible component, and it is around 3 to 5 centimeters. Okay, clear about this anatomy? Okay. So it is composed of the right and the left ganglia, and the major sympathetic visceral innervation is as follows. It innervates the gastrointestinal tract, which I have already told you. Okay, it is almost around 3 centimeters in length and 4 centimeters in width. So total 3 to 5 centimeters roughly the celiac plexus is. So it is not a very small plexus, it is a huge plexus, okay, or a huge ganglion. All right. So this is how it looks. So it's a cut section. And if you see, this is the aorta which is sitting at T12 or L1 vertebral body. This is your IVC. And you see these white structures on either side of the abdominal aorta is your celiac plexus. So that's why we do perform a celiac plexus by two needle techniques. We come from left and right. Now the thing is that when you come from left and right, I usually come from the left initially, Anyway, we are meeting on our workshop. I will explain you in very much details again there also. Why I do again a left side, I will tell you. So why I do a left side is that because there is something called a left side, there is a aorta. Okay, so I can say even unintentionally or non-intentionally, we pass through the aorta most of the times. And when I pass through the aorta, I just go through anterior abdominal aortic wall and I inject. And when you inject there, we had seen that the spread is so good that it spreads to the bilaterally, and one needle technique is enough to cover the entire ganglions. But we give a lot of amount of the drug, around 20 ml of alcohol, to block that area. So that's why I perform first left side and then I perform the right side. If I don't get the aorta from the left side, then I do a right side. Then I do two needle technique. Other one needle technique is enough. Okay, so that is how was the importance of the aorta. Okay. So this we are not going into the details. So there are various indications. Now I told you which organs it supplies. So that organs, if they are damaged and if they are in pain, so you perform a celiac plexus block or a splanchnic nerve block to that particular pain syndromes. So chronic pancreatitis, I usually don't encounter much, but pancreatic CA pancreas, that's a very commonest indication in my practice. Gastric carcinoma, esophageal carcinoma, very less I do for esophageal, but gastric, pancreas, biliary, liver, I do a lot. Retroperitoneal also I do very less. Okay. And it has been reported to be beneficial in managing nausea and vomiting in patients with pancreatic cancer also. And this is attributed to the effect of plexus on the gastric motility. So it increases the peristalsis. That's why if you see when you give a celiac plexus block, the patients, most of the patients complain of diarrhea for 24 hours. Okay. That's why it also helps in a certain group of patients who have that. Contraindications always very common in patients who are on anticoagulant therapy or who have coagulation abnormalities. Now, one thing we have to understand in this group of patients, especially the pancreatic cancer, biliary carcinoma, liver cancer, and liver metastasis, most of the times they do have or do present with coagulation abnormalities. Sometimes their INR is deranged. So it is very, very important to do this test INR. I always see to it that I ask for an INR in all this group of patients for two reasons, because the primary itself, which may cause coagulopathy, and second, because I may pass through the aorta, or I pass most of the times to the aorta. That's why I ask this. Otherwise, what will happen? There will be a retroperitoneal hemorrhage and the patient may die because of hypovolemia and bleeding, which should not happen, right? So do no harm. So that's our dictum always. And that is why I always ask for coagulopathy, coagulation status in all of these patients. Yes, again, if there is an infection and sepsis, better not to touch or not to do any interventions. Always in your life, remember that. Okay, whenever the patient is having some sort of infection anywhere and sepsis, please don't intervene. See, patient is never going to die with your pain. Okay, if you are not treating the pain, he will not die. He may suffer. But if the patient has infection and if you're doing some intervention, it is more, they will attribute it to that infection. And if the patient has sepsis and if you're not able to control the sepsis, they die. So this we should not want. We don't want in our practice. And I'm telling you, please always do a safe practice. Okay. Never ever hurry ki are yaar, we will do kuch nahi hota hai, dekha jayega, and all those things. Never do that. If the patient is having an infection or a sepsis, pharmacological management, I will come to the recent systematic review about the blocks, what they say when they compare your interventional therapy versus systemic analgesic therapy. We call it as SAT versus interventional therapy. So that's why it is very, very important to understand this. So pharmacological management, if you do it adequately, if you titrate the medications very well, I'm telling you, and I can bet you, if you ask me my intervention rate, I will tell you in the literature, all over the world says it is 1 to 5%. Mine is only 1 to 2% interventions. So they can be very well managed with the pharmacological agents. Our interventions, they just do add as an adjuvants, and still they need a systematic analgesic therapies. So be very careful when you are selecting these patients. There are many indications, but selection is by wisdom. Okay. Just give me a minute. Hello. Hello. Then meeting lo unnachchu. Okay, bye. All right. So local or intra-abdominal infection or sepsis, yes, please don't do that. Again, it should be avoided in patients with bowel obstructions. Why? Because of this. There's a unopposed parasympathetic activity because you're blocking the sympathetic chain. Okay. And if there is an unopposed parasympathetic activity, there will be a hypermotility of the gut, which may cause, because of the obstruction, may cause perforation. So that's why you should not. And again, if you're using, because we use as a neurolytic agent of choice alcohol, it should be avoided in patients who are on disulfiram or therapy for alcohol abuse. Okay, clear? Equipments. So what is the armamentarium? We always need needles. So that's commonest things. So what I use is we use a 22 gauge spinal needle. 10 centimeters most of the times is not enough to reach the target site because of many reasons. Because of the angulations, the length increases and it is not an ideal thing. But what we use is that we have a BD needle, our spinal needles, which are supplied by BD. It's a 15 centimeter to 70 centimeter spinal needles. They are very good. Chiva needle is a very expensive needle because it costs in thousands. So I don't think we should pay so much money only for the needle. You get a spinal needle which is 15 to 17 centimeters. That is enough. Okay. And some people may use an angiocath for placement of the blunt needle. I don't use a blunt needle. I use a Kunkis proper bevel, which is a sharp bevel. I use that needle only. But if you're using a blunt needle, because to puncture the skin is the toughest structure to puncture with a blunt needle. So some people may use an angiocath. Drugs, local anesthetic. We don't use steroids. We use alcohol, that is 50% alcohol. 100% is not available. It is always 95% which is available. And around 20 to 30 ml. If you're using on both sides, both needle technique, 20 ml, single needle technique, 20 ml is enough. Preparation of the patient, I again told you that I always ask for INR. That is very, very common. And if we are suspecting some infection or we want to rule out an infection, you can ask for a CBC, which highlights your WBC count. We review an MRI. Why? Because to understand whether there is a plane in front of the, in between the pancreas and in between the celiac trunk. So what happens is that, especially in CA pancreas. So in CA pancreas, there is an infiltration of the pancreas in that entire area. So because of that, there is no plane. So if there is no plane, when you go, you are injecting either into your pancreas or you don't know where you are injecting. The injected won't spread properly. It may be loculated because of the disease which is there. So that's why it is very, very important to study the MRI. And what we do is that we ask our radiology colleague. I just call up and ask them, can you just comment whether there is a proper plane in that area or not? And if there is not a proper plane, then we go ahead with a splanchnic. Okay. Otherwise, I always perform a celiac plexus. Then our standard recommended protocol is by the ASA for the conscious sedation, if at all it is needed, or the standard monitoring. What we perform is that we take an IV line with a 22 gauge needle or a vein flow. Then we just run a fluid. We do a BP monitoring, NIBP monitoring, and pulse oximeter monitoring. We don't usually put leads. Pulse oximeter, the plethysmogram itself tells you about the pulse rate. And it also tells you the volume status, the plethysmogram, and saturation. And the BP gives you the BP. So this is what we usually do. So for the procedure, now there are various ways we can perform the procedure: posterior approach, transdiscal approach, paraspinous posterior approach, transaortic approach, anterior approach. Okay. So these are many approaches. which can be performed when you're doing a celiac plexus block. So this is a posterior classical retrograde approach. This approach okay, is a Moose triangle, we call it as okay, from the 12th spinous process, the thoracic vertebra T12. Okay, and from the L1 we draw a horizontal line almost 7 centimeters to 8 centimeters away from the midpoint on both sides, and we draw angulated line which bisects this horizontal line and bisects the tip of the T12 spinous process, and this forms an isosceles triangle, and from there we puncture and we move towards the vertebral body. This is a blind technique. Okay, but we use fluoroscopy, so there is no need that you have to go this much centimeters away, that much centimeters away. It is based on your trajectory of your C-arm rays or a fluoroscopy rays. So based on that, you can do the puncture or your entry site. Okay. So this can be performed using a C-arm, and this can be performed using your ultrasound, or this can be performed using a CT scan also. So it depends what you are comfortable with. So in my practice, in our institute, we always use a C-arm. Ultrasound we don't use very much because what happens is that when you pass through, especially for the pancreas, so the cancer cells may spill because you are forming a track, and there will be a seeding because you are passing through that cancer through the pancreas in an anterior approach. So there will be a seeding of the cells into that area. So there will be a local spread. That's just a theoretical thing. Okay. That's why we usually don't do. And also availability of the ultrasound is another important task. So we have an easy availability of C-arm, and that's the most common way of blocking it. We use it. Unless and until there are situation in which the patient can't lie down in a prone position because of the stoma bag, then we can think of ultrasound. Otherwise, we don't perform ultrasound. This is a way we usually perform. Now, if you see this, okay, AP view, we already know we have to square the vertebra, you have to select the vertebra. Now, again, it depends what are you doing. You're doing a splanchnic nerve block, or you're doing a... my speed is okay, or do you want me to hurry up? Hello?
Sir,
Okay,
this is
sir.
perfect. Sir, fine, sir.
I'm not boring, no? Because I'm going
No,
very
sir, no, sir, not at all.
No, sir.
so that I make you understand very clearly. Right, yeah. So, APV we do, you all know APV has already been taught. So if you see this squaring of the vertebra, if you see only one line, you have to see not like these two lines. Okay, one line, one line. So that is, we call it as a squaring of the vertebra. This is a recent patient, I think 1 month back only I did this patient. So where squared this vertebra, I was going at the L1. So L1 means always celiac plexus. If you are at T12, T11, higher positions, it is a splanchnic now. Always remember this way. Okay. So if you see the squaring of the vertebra I have done, and you see the Scotty dog, the transverse process. Okay, it is coming like this. This is the up four limbs. This is the hind limbs. This is the tail. This is the body. This is the ear, and this is the eye. Right? Okay, that's the Scotty dog. So now what we do is that you move your C-arm towards the ipsilateral oblique. Now I already told you that I perform from the left side first. So I move my C-arm towards the left side first. Okay. So to what extent, usually when we do a transforaminal or a facet block, for a facet it is 5 to 10 degrees. But for a transforaminal, we usually go up to 20 degrees. But here it is not like that. Okay. So what we can do is that you do the tilt, oblique tilt, till. See, this is the transverse process. Till the transverse process aligns with the lateral border of the vertebral body. So this is the border of the vertebral body, right? So till it aligns, or till you won't see the transverse process out of it. So it should just align. Okay. At that point, you know, see, this is your proper oblique angle, and in a trajectory view or a tunneled view, you enter it and directly go and hit at the junction of the transverse process. So this is where is my transverse process and the junction of my vertebral body. I go and hit. Okay. You can see my needle. So this is how your needle should look in an end-on view. Okay, got it? Clear?
Sir.
Anyone? Okay. Or should I repeat it again?
Yes, sir. You can repeat it once more, sir.
No problem. Okay. So we always, whatever vertebral level you are choosing, there are only two vertebral levels you have to choose. The celiac plexus in structurally, if you ask me at fluoroscopy level, it is at the lower 1/3 of T12 and upper 1/3 of L1. At this level only you can perform celiac. If you are going above that, that means you are doing a
Landing.
Okay. So lower border of T11 and upper border of upper 1/3, 2/3 of T12. Okay. But now if you see my needle, it is at the upper border of upper 1/3 of L1. So I'm doing a proper celiac plexus. Okay. Now AP view. This is not AP view. This is an oblique view. I put a picture. But in an AP view, you have to square the vertebra. That is most important, right? And then you do a ipsilateral oblique. Ipsilateral oblique means towards the side which you want to block. So I'm doing a left side. I will move the CM towards the left oblique, ipsilateral side. So till where the nose of the Scotty dog, that is the transverse process, comes in alignment with the low lateral border of the vertebral body. This is the lateral border of the vertebral body, right?
Yes, sir.
Yeah. So till it touches there, till that moment you have to do your oblique tilt. Okay. Then you stop it, and then in an end-on view, you just enter your needle and go and hit the bone. Clear?
Okay, sir.
Okay. So in a lateral view, you will see this is the anterior body of your vertebral body. Okay. Now, many people ask me one question, sir, how much anterior we should go to the anterior border of the vertebral body? Okay. It's a question of gold. There is no answer, perfect answer for that. So what we usually do is that if you see this AP, you see my picture, this picture. So it is aligned properly. Okay, there's a squaring. Okay, now this is your spinous process, right? You can see my cursor moving on the
Yes,
diagram.
sir.
Yeah.
Yes, sir.
These are your pedicles. This is your transverse process, right? See, this is only one needle technique I used. So it should cross. This is the medial plate. This is the lateral plate of the pedicle. I think you might have encountered this terminology: medial plate and lateral plate of the pedicle. Okay. So you have to cross the medial plate, but not cross the spinous process. Got it? In an AP view, that should be the end point. So it doesn't matter in lateral how much anterior you are. Got the point? Should I repeat?
Yes, sir. Yes, sir.
So the question, the $1 million question is that, sir, कितना आगे जाना चाहिए anterior border से? 1 centimeter, 2 centimeters. So there is no answer, particular answer for that. So what we do in an AP view, we go till it crosses the medial plate of the pedicle. But it should not cross the midline of the spinous process. So इनके दोनों के बीच में रहेगा ना, that is the ideal end point. Okay? For the lateral view. So it doesn't matter if it stays here or here. Okay? Clear?
Yes, sir.
Now, sometimes it may go, sometimes it may cross over, but you have to see when it crosses over, sometimes you may in the aorta. So what we do is that when we are in that place, we just take out the stellate and we see the backflow. And if there is blood coming out, it will not come as a spurt. It just drop, it just spills over. I say girte rehta hai blood. Okay. So you go, you aspirate, continuously aspirate and go. Always aspirate with a 2 cc syringe. Aspirate and go till there is no blood. So in such situations, sometimes you may touch the midline or sometimes you may cross over. But ideal position is this, in between these two. Right?
Sir, but we started at L1, but the needle is at T12.
No,
Thank
This is L1 only. This is treatment. This is L1.
Let's see.
Yeah,
This
he
is
was
the
stable
this
with
is
that,
L1,
don't
right?
worry.
Thank you so much. Thank you.
Hello.
Bye.
Hello.
Hello.
Hello. I'm not talking about this diagram.
Okay, sir.
I'm talking about this diagram.
Okay.
See, if you see this, okay, I'm talking about this diagram. This is
Okay.
this is my picture.
Yes, sir.
This diagram I'm talking. Okay.
Okay, sir.
This is the same patient, Avinash. 7.5, you can see here. Either nahi dikh raha 7.5. Okay, ठीक.
Got
Okay,
it.
so this is the same patient. Okay, you got it, no? Don't
Yes,
get
sir.
confused. Don't look at this picture. I'm talking about this particular picture.
Okay.
All right. So this is L1 only. Okay. Clear?
Yes, sir.
So that is how we perform. Okay. So now there's a lot of dilemma or school of thoughts. कि अभी आपने सिंगल नीडल टेक्निक, आई यूजुअली डू सिंगल नीडल टेक्निक, लेफ्ट से जाता हूँ, आयोटा पंक्चर करता हूँ और चला जाता हूँ और मैं इंजेक्ट करता हूँ. अभी क्या इंजेक्ट करना है? व्हाट टू इंजेक्ट? लोकल एनेस्थेटिक और अ न्यूरोलाइटिक एजेंट. Now books say that you do with a local anesthetic, and if there is a good block, then you call the patient for a next sitting or the next day for a neurolytic plexus block. But my practice has taught me one thing is that if the patient never comes back. Okay, I work in a government setup. I charge only 1,500 rupees. Still they don't come. So there's a lot of dilemma. So क्या करना है क्या नहीं? So what we usually practice is that we give 10 cc of local anesthetic. We keep the needle like that only, and we wait for 10 to 15 minutes. And we see if there is a block, patient has a pain relief or not. And if they have a pain relief, okay, then we inject the alcohol. But before injecting the local anesthetic, we always inject a contrast and we see the spread. Okay, there should be a uniform spread. Okay, there should not be a loculated spread or a columnar spread. If there is a columnar spread and all, you mean you are in the intestine or you are in the pancreas. Okay, so there should be a uniform plane spread or a proper dispersion in an AP view, and in a lateral view, a plane spread. Then you know that you are in the proper right place. Okay, and then we inject the neurolytic agent. Clear? Till now, any issues? This is for the anterior. Okay, they say 2.5 centimeters from the xiphisternum and 2.5 centimeters lateral to the to that point is your puncture site. Okay, in ultrasound. This is what is ultrasound. But again, ultrasound, you just put the probe wherever you see the celiac trunk, you inject it. Okay. So these are the various complications. Now, 1, 2, and 3. These are the 3 most common complications, of which pain during and after the procedure is a very common complication. Most of my patients, they always come back to me and say that I had a back pain. Because of the needle length and the needle movements, no, because you are passing through so much of extensive muscle thickness, there's a lot of injury to the muscle and it causes a lot of soreness and they have pain. So what we usually suggest is that we just ask them to apply ice. That's the only thing we advise them. And if NSAID is not if NSAIDs are not contraindicated and if the ice is not helping them, then we tell them to take it on a SOS basis. NSAIDs. Otherwise, hypotension, orthostatic hypotension, or diarrhea. These are the two another commonest, or I will say these are not complications. I will say these are the sequelae. These have to happen. Okay. So hypotension happens if you are doing a splanchnic because you're blocking more of the cardiac sympathetic fibers, and diarrhea will happen if you're doing a celiac plexus above the diaphragm and below the diaphragm. That is you remember. So above the diaphragm is always splanchnic and below the diaphragm is always celiac. Okay, and these are very self-limiting sequelae. They never happen for more than 12 to 24 hours. Only one patient till now, means I will say for the last 20 years, I had seen only one patient where he needed an admission for diarrhea. He was having loose motions for almost I will say more than 1 day, not up to 2 days, but more than 1 day. We admitted him and we had not given anti-motility drugs. We were just observing and we were just hydrating him. That's it. These are the other complications which are very uncommon. I had not encountered any of this till date. These three I always encountered. This renal injury, it's very difficult to say. One patient had told me that he had hematuria, so that I didn't means I could not means that time I could not connect that with my procedure. So I thought, "Arey, renal injury kyun hona chahiye?" and all. But it can happen, and he presented with hematuria, not just 2-3 episodes of hematuria. But other things are very uncommon. I have not encountered any one of this. Okay, you may encounter. I'm not saying that you will not, but these are the possible complications and sequelae after performing a celiac plexus block. So coming to the evidence, now there are papers till 2005, and there is now one paper which has come in, I think 2020 or 22. I will tell you that. If you see, these are RCTs, and there are 2 non-RCTs. Okay, and commonest type of cancer, you see only pancreas. Okay, and a good number of patients they have done, and this is a meta-analysis which has included all these studies. Okay, and they say there is an excellent pain relief in 89%, almost 90% in the first 2 weeks, and after 3 months, partial to complete relief in 90% of the patients. Okay, imaging doesn't influence. If you see, there is a fluoroscopy. This one is an intraoperative neurolysis. While operating, they have done that. You can see a celiac ganglion, and they directly injected it. This one is via thoracoscopy. This is endoscoping USG. Okay, so it doesn't influence. So imaging influence is not there on the pain relief. Whatever modality you use or whatever imaging modality you use, there will be the same pain relief if the block is perfect. And you see only 3 common side effects: local pain, diarrhea, and hypotension. Okay. Now, this is the meta-analysis or the evidence-based narrative review I was talking about by Wong et al. His group. Okay, and what they have done is that in 2020 they had published this paper, and total 13 prospective randomized trials, 5 systematic reviews and meta-analysis, and 1 Cochrane review. They were found to meet the eligibility. So they did a literature search through PubMed, through Embase, and through scholars, and they used the MES terms: celiac plexus block, intra-abdominal malignancies, CA pancreas, CA stomach, neurolytic celiac plexus block, only celiac plexus block, celiac plexus. So these were the terms which they have used, and they could get only this much of the data. And if you see this, neurolysis of the celiac or splenic plexus is an effective and safe therapeutic modality. Okay, they are saying it is effective and it is safe. That should be considered early for palliation of cancer-related pain in advanced upper intra-abdominal malignancies. Now, you see this statement. This is especially true for patients with intolerable opioid-induced adverse effects. What does that mean? This statement in this review says that the patients are very well managed with opioids, but if there are intolerable opioid-induced adverse events and painful symptoms resistant to oral analgesics, we can consider this block, which is effective and safe. See, the papers, it just depends on how you interpret it. Everything in your life is based on your interpretation. So, situational it is all. So, based on the situation. Now, for example, if a patient comes to me, is coming from Northeast, okay, and I know that he has a lifespan of around 4 to 6 months. We prognosticate the patients in palliative care, and I know that this patient is not going to live for more than 6 months, and he's just on opioids, mild doses. And I know in the Northeast opioids are not available. Then I can directly give a block and send him off. I can do that. Okay, so that's what I'm saying. Everything is very situational things. It depends on how the patient comes. In private practice, patient comes with the to the pain specialist with an indication saying कि इसको block लगाओ. So the oncologist sends to you, इसको block लगाओ. Okay, so it varies. So there can be a lot of discussion and arguments कि कौन से पेशेंट में देना है, कौन से पेशेंट में नहीं देना है, इसको ही क्यों दिया आपने, उसको क्यों नहीं दिया आपने, आप क्यों नहीं देते हो, अरे ये क्यों देता है ज्यादा. So that argument continues. So my opinion is that your selection has to be very, very proper and based on the availability of the things. See, I have an availability of the expertise, I have the availability of the medications, I have the availability of the imaging modalities. But still my conversion rate from systemic analgesic therapy towards the interventional therapy is only 1 to 2% because there are many things to it. Now we start them on oral opioids and by the time they come and we think they are taking chemotherapy and by the time we think, okay, they are declared best supportive care and now no longer cancer directed therapy. And by that time the cancer is advanced because when the cancer advances or there is a progression, disease progression, then only they will say, okay, we will know for further give him a chemotherapy. Or second indication is that if the patient's general condition deteriorates or renal functions or some of the liver functions are deranged, then they don't give chemotherapy. So in such situations, what happens is that my selection becomes very restricted because suppose if this patient is there and they are saying that his renal function or liver function kharab hai, and I do an INR, uska INR is deranged. So I will not do a block in this patient, right? Definitely, it's not an indication. So there are various factors into it. So it's not that कि CA pancreas है तो इसको upfront ही देना है या इसको upfront नहीं देना है. There's a lot of thoughts into it. I will say a lot of wisdom is needed and your clinical judgment is needed whether we really need to give this block to this group, this patient or not. So each patient has to be tailored, has to be met with the needs in near future, whether he is getting an analgesic therapy. And again, it depends on the patient also. They may accept or they may not accept needling. When you explain to them about the possible complications. And one of the possible complications you always tell, I don't know whether people tell or not, but I always tell is that you may have nerve trauma and that may lead to weakness of your lower limbs. So, so patients are taken back. They will say, okay, why don't you just try the pharmacological therapy? And we have a good amount of pharmacological drugs which are available easily nowadays. So this argument and discussion keep on going, and we can also discuss and argue when we meet in person in Bangalore. Why is it not moving? Wait. Okay. Okay. So if you see this neurolytic blockade of the celiac plexus can be used safely in cancer patients for analgesic controls. It provides superior pain control and analgesic sparing effects. Okay, up to 6 months. But you see this statement, huh? That's why you have to read the paper properly. Just ऊपर का title पढ़ के और थोड़ा सा abstract का conclusion पढ़ के don't make a judgment. Now, if you go inside the paper, now I have taken this properly from the inside the paper and they say up to 6 months, particularly when combined with SAT. What is SAT? Systematic analgesic therapy again. So just as a only block, just a block will not help the patient. It has to be always combined with a systematic analgesic therapy again. सिर्फ ब्लॉक दिया और बोला अरे 100% रिलीफ हो गया. You will see many masters in our pain groups. Okay, many masters. अरे बहुत यानी मेरे से भी एकदम 30 मार खान लोग हैं. Well, they will say अरे हमने ब्लॉक दिया 100% pain relief. I don't know how it happens. So they have magical hands. I don't have a magical hand. Okay, but you will see this. Eventually, अभी आप practice कर रहे हो, अभी आप pain group में आओगे, you will interact with many people. They will say, yes, I had given a block. 100% काम करता है, कुछ नहीं होता है. Okay, but I very honestly say, and this paper also is saying that particularly when combined with your opioid therapies. Okay, at the present time, the data concerning NCP for improved survival and quality of life. Okay, so the blocks will not improve your overall survival. Patient को अभी 6 महीने में मरना है तो वो मरेगा. It will not improve. Okay, again, there is also no evidence of superiority of neurolysis of celiac plexus or splanchnic. So it doesn't matter whether you're giving a celiac plexus block or you're giving a splanchnic nerve block. Okay, both the efficacy is same. Okay, now there are many predicting factors which will contribute to the efficacy of neurolytic celiac plexus block, and they include disease progression, metastasis, operator experience. This is very, very important. Operator experience. आपको लगता है या हमको लगता है हमने ब्लॉक दे दिया, काम नहीं किया. But how much is your experience? How can you say that you had given the block and the drug which you had given, it has spread adequately and it has blocked the entire celiac plexus? वो थोड़ा सा cover किया रहेगा. So that failure is always bound to happen, right? So we have to accept that. Again, location of the tumor burden, and the injected spray, right? As I already told you. So it depends on many things. Okay, it's not that कि block दिया काम करेगा ऐसा. Another thing, alcohol and phenol, they are equally effective. It doesn't matter. But why many people choose alcohol? Because if you use phenol, phenol has a propensity towards the blood vessels and it may erode the wall of the blood vessel. So that's why any area which is closer to the blood vessels, you don't use phenol. Second thing, phenol availability, because you have to make it fresh. Because phenol is always available as a crystalline powder. So you have to either mix it with glycerin, the commonest one which we use. Okay. So you have to mix that with that and you have to make a fresh preparation, and it has to be a sterile thing. Alcohol itself is a sterile. We use alcohol for sterility, right? So the question of sterility doesn't arise for alcohol. And if you see the shelf life of phenol, the freshly prepared shelf life, if you want to use it again, is 4 to 7 days. After that, again, you have to freshly prepare. So that's why we usually don't use phenol. Alcohol is a better option. For peripheral things, I usually use. For intercostal nerve blocks, I use a phenol. Okay, and if I want to use intrathecal neurolytic agent, especially for a perineal pain, I use phenol because it is a high baricity, so it will settle down, hyperbaric. Okay, so there are certain indications where we can use phenol, but most of the time I use alcohol. Okay, so the optimal volume is controversial, but 40 ml is adequate. Okay, I use 20 to 20 ml. Okay. Then we conclude that early application should be encouraged. To serve, again, you see the statement, to serve as a supplement to multimodal analgesia. Okay, it's not the only thing. It's not all or none. कि block दिया या नहीं दिया, ऐसा नहीं होता है. Block दिया तो सिर्फ और कुछ नहीं देंगे, ऐसा भी नहीं होता है. Okay, and the decision to employ should be always be individualized, incorporate the patient's preferences and weighing the risk-benefit profiles. Always. It's a very recent paper, 2020 में आया है. We will share that paper with you. Okay, please read this paper. All right, so these are the various papers which they have analyzed. Almost 13 papers they have analyzed it. Okay, all right, so any questions till now for celiac plexus block? Then I will move on to the superior hypoglossal plexus. I'm open to questions, or we can discuss it when we meet in Bangalore. Or hello.
No questions, sir.
There are only
any widespread pictures of that, sir.
Actually, I had put it. I don't know. Somehow, I think I had opened up maybe a different presentation. Maybe I am very sorry, because even I was wondering why my die picture is not coming here. I don't know. I'm sorry. I mean, we will show you that. Don't worry about that later on. If I get it, I will share it. I will share the pictures in the WhatsApp group if you want. Okay. I'm very sorry. I made the slides, but I don't know why it is not coming. Maybe I have opened up another presentation. Yeah, tell me.
Sir, CM position, ipsilateral oblique view we are keeping now, sir.
Yeah.
Then definitely we have to look into AP view now. So better to go AP view and then lateral.
Always start with AP view. I always also I told you AP view may you have to square the vertebra always. After squaring the vertebra, after knowing the level of the vertebra, then you go to the ipsilateral oblique.
Ipsilateral.
Yes.
Okay.
Always.
Then once you pass the needle, then lateral, and then again AP view.
No, in the ipsilateral oblique, you go end on view, go and hit the bone at the junction of your lateral border of the vertebral body and the transverse process. and then you go lateral.
Okay, sir. After that, you told no, to check again in the AP view.
Yeah,
then
again you check in the AP view. You check in the AP view that I will pass to the medial plate of the
medial.
pedicle.
Okay, sir. Okay. Okay, sir. Thank you.
Clear?
Yes, sir.
Any questions? Any more questions? Should we move on? Can I take a 2 minutes break?
Yes, sir. Sure, sir.
Thank you. I'll just go up to the loo and come. All right. Okay.
Sir, I have a doubt, sir.
Yeah.
Whether we should prepare the patient, bowl preparation is needed, sir, for
No.
posterior view. Because I read somewhere anterior ultrasound, when you are doing, better to prepare the bowl actually.
Ultrasound also, it's not necessary unless and until there is a lot of gas, then your view may be obscured in ultrasound. But in posterior view, fluoroscopy guided, no need.
Oh, okay, sir. Okay. Thank you, sir.
Okay. Hypogastric plexus. Now the landmark is L5, always at the bifurcation of the aorta. That it's a plexus. It is not a ganglion. Celiac is actually a ganglion. This is not actually a ganglion. Okay, it's a network of the nerves. Okay, and there is something called as inferior hypogastric plexus. We don't usually do because it is embedded into the all the peritoneum and all. So, and it is also difficult to access. So that's why inferior hypogastric plexus is not done. Sometimes most of the people, what they do, there is a pelvic pain and the differentiating component is not there between the perineum and the lower abdominal pain. So they do both. They do an hypogastric plexus as well as a ganglionic bar. Okay, and they get the entire pelvic pain control. Okay, so superior hypogastric plexus, the anatomy, it's an extension of the aortic plexus again at the level of the bifurcation of the aorta. Okay, so fibers from L2 and L3 splanchnic nerves form the superior hypogastric plexus, and it also receives fibers from the lumbar sympathetic nerve of L5, and it is in continuity with the celiac plexus as well as the lumbar sympathetic chains above, and it innervates the pelvic viscera, that is the bladder, the uterus, the vagina, prostate, rectum, via the hypogastric nerves. Okay, so this is where, if you see from the lateral view, okay, so this is where your plexus is there. Okay, it's a network of the nerves, and I will tell you, it is a very challenging procedure if you're doing it fluoroscopy. USG guided, it is easy, but I don't do much USG. I always do it fluoroscopy only. But it is a very challenging technique when you're doing it by fluoroscopy. We'll come to that. And it is situated on the anterior aspect of L5 and S5, or on the disc between the L5 and S1. Again, you have to understand the ureter is located just lateral to these structures and close proximity to the anterolateral aspect of the L5 vertebral body. So you may damage it. Okay, it is sympathetic. Okay, and distally, the superior hypogastric converges and form the hypogastric nerves, and it supplies the entire viscera. All right. The inferior hypogastric plexus in turn consists of fibers from hypogastric nerves. They are postganglionic sympathetic fibers from the sacral splanchnic nerves, the parasympathetic fibers from the pelvic splanchnic nerves, the cell bodies of which are located at S2, S3, and S4 levels. So this is the inferior hypogastric. Okay, but it is a very difficult thing to access the inferior hypogastric. So we usually do a superior hypogastric and the ganglionic, if you want to. Now the indications: any pain which is originating from the pelvic viscera, gynecological disorders, endometriosis, adhesions, interstitial cystitis, irritable bowel syndrome, and malignancies in the pelvic viscera. So this is where I commonly perform my blocks for. Contraindications, again, local infection and coagulopathy. This you have to always understand. Equipment is the same. Okay. One more drug I always forgot is the Ioxol or the Omnipac. This is a radiopaque contrast. You have to always keep it. Okay. So there's a way of blocking it: classic superior hypogastric block, or a transdiscal superior hypogastric block, or the anterior approach. I usually perform the classic technique, which I will tell you. Transdiscal I usually don't perform because my opinion is always don't touch the disc. If you touch the disc, you hide it. The patient will always complain of backache, and it is a very difficult thing to manage. And if they have a discitis, you hide it. Okay. So I usually don't try to do, unless and until, if you ask me theoretically, there's a possibility to do if your patient's lifespan is very little, then it is okay. But I will not advocate transdiscal superior hypogastric. I will always tell you to go with the classic superior hypogastric. Now, fluoroscopy, if you're using, is there are 6 steps always when you do a fluoroscopy. Identify the target area. What is your target area? L5, S1. Okay, that's the junction. That is your target area in an AP view, and in a lateral view also L5, S1. Okay, that's your target area 1. Okay. Second is position the patient. Patient is always placed prone, again, same way what we do it for a celiac plexus block. Okay, these steps also apply for any block you do, including the celiac plexus, which I previously told you. Position the patient. Okay, that is the second step. Okay, then this is your L5 and S1 junction. Then site of needle entry is very important. Okay, technique of needle entry: medial approach. Okay, all right, I think I'm repeating the slides. Okay, positioning the patient has happened. So now, after that, positioning the patient, the third step is use the CM to identify the target. And I already told you your identification of the target is L5, S1. Okay, then insert the needle. I will tell you how to insert that. We will come to that. Confirm the needle placement. I'm just telling you the points what to do. Okay, confirm the needle placement and inject the medication. So these are the 6 steps whenever you are using a CR. First step is identify the target, position the patient. All right. Then use your CM to identify the target. Then insert the needle, confirm the needle placement, and inject the medication. These are the 6 steps of any CM procedure. Right. Now coming to the needle intersect. And if you see this picture, now again, this is also an ipsilateral oblique. Okay. Now here, the thing is that you have to target the CM. So this is my picture, I'm telling you, to such a position that the transverse process of your L5, if you see, this is the transverse process of the L5. Okay. This is your iliac crest. Okay, and this is your lateral border of your vertebral body. You can see this structure, this opening. This is the only space through which you can enter your alpha S1. So the problem is that either you can hit your transverse process, either you can hit your body, or you can hit this purse of your vertebral body, or you can hit the iliac crest. So you have to negotiate this. So this is the only window through which you can negotiate. So that's why I say that this is a very technically challenging modality which you are using, fluoroscopy. Okay, so you have to see to it that the obliquity of your CR should be such that you get this window. And what is this window? Transverse process. Your iliac crest is coming like this. Okay, and your ala is there here, but at the same time your vertebral body is there. Okay, so this is what is your window. You get this window, then you can just go into this in the tunnel view. This is what it is, and this is how you pass your needle. Okay, and again it is just anterior to the, here it is there. You have to be just anterior to the anterior border of your vertebral bodies. Okay, not more than 1 centimeter far away. Just within 1 centimeter is enough when you're performing this block. And this is what, you see the needle, the way you are aligning this needle, the needle becomes curvy, so much curvy because it is hitting the bone so many times. Okay, and you see the spread, and this is the linear spread. This is the same spread you can see when you are performing a celiac plexus also. And this is a dispersion, proper dispersion, plane dispersion of the spread in the APB. So this is how you can get it. So now this is the window I was talking about. Okay, now you can see this is ala, sacral ala. So here the sacral ala is very prominent in this patient. This is your iliac crest, and this is your transverse process. So you have only this much window. Getting the point? So it is very important and very technically challenging to get that window. Okay. Again, if you see here, the window, only this much window. Here, if you see this vertebral body, it is almost touching the iliac crest. So, technically challenging procedure, but a doable procedure. It is not that you can't do it. You can do it. Now, the common problems, there are certain problems when you do this technique. So, you may touch the alpha nerve root, because if you see the alpha nerve root comes from here only. So most of the times the patient moves a lot, jerky movements they do, because you are touching the nerve root most of the times. Okay, and the needle tip may be too lateral, because sometimes what happens, you are hitting the bone and the direction of the needle is changed. Okay, so if it is touching the alpha nerve root, just redirect it. Intravascular spread, you already know what to do. Aspirate, go. Okay, if it is too lateral, you just withdraw and redirect the needle. So what is the evidence? There are numerous reports exist regarding the effectiveness of this block for the management of pelvic pain associated with cancers. Okay. If you see Plancarte is a very good physician. I think he's from Mexico. He's a very old guy, and he has done a lot of work in cancer pain, and he still does. He's still alive. Okay, and he reports a significant decrease in pain scores after this superior hypogastric plexus block for patients with cervical, prostate, and bladder cancer. De Leon is another guy. He's from US, works at New York. He also reported that 69% of the patients had significant reductions with SHPB for pelvic pain arising from gynecological, colorectal, or urinary cancer. Okay, so this is what is the evidence, and but again, we have to see that the opioid use has been decreased only by 40%. It doesn't mean that if you had given any block. See, why I'm trying to imbibe is that I had seen many people, young guys, the way they talk when I meet them in many of the conferences, or when I meet them personally, the way they talk is that, "Arey sir, हमने तो block दिया और patient का पूरा medications बंद हो गया." I don't believe. I don't know how it happens to them, but you always need to give pharmacological therapy, certain form of pharmacological therapy. And if you see the neural epilepsy reduced pain by 50%, for 1 month in 72% of the patients who responded to diagnostic blocks, and 51% of all the patients that enrolled in the study. Again, you see only half of the patients got benefited. Okay, this is what is the evidence says that. Transdiscal is an alternative approach, but I will not advise you to do that. Okay, transdiscal approach may particularly help as a rescue technique if the classic approach is not possible due to anatomical limitations. Yes, you can do that in that situations. Now, if you see the ultrasound, so this is what I was talking about, the bifurcation of your aorta, and you see your L5 vertebral body. You just insert the needle and just hit the vertebral body and withdraw by 1 millimeter and just inject. That's it. Nothing doing. Okay. So this is what I was talking about, your common iliac vessels. And this is where, this is the entire place where is your plexus. You come from here, hit the bone. You have to always hit the bone, withdraw 1 millimeter, inject. That's it. Now here, the bowel evacuation is important because most of you are, because it's a pelvic component, your rectum and all are there over there. So it may impair your visions most of the times. Okay, you place a pillow to reduce the lumbar lordosis, and CT guidance is suggested when the tumor is infiltrating the SHP. Even for a pancreas also, anterior approach or a CT guide is always preferred if the tumor is infiltrating. But I usually go for a splanchnic nerve block for that procedures. Okay, so I think this we had covered already. Okay, and these are the complications. Okay, nerve root injury is the complication which I had encountered during my practice whenever I enter the needle through that particular area. Intravascular injection is another complications which I have encountered. Bowel puncture and all I had never encountered. With one simple needle, 22 gauge bowel puncture is not a big deal. Transdiscal I have not done, but theoretically, if you ask me, these are the certain complications which can happen, and discitis is something which I will not accept. If you are performing a block and the patient has discitis, I will say that you are a fool, you are an idiot to perform such block. Okay, don't ever perform unless and until those two conditions which were already discussed. All right, so any questions for this? Okay, we'll go ahead. Ganglion implant, again, it is a continuation of the sympathetic trunks. Okay, and if you see the sympathetic trunks, they come and at the level of the coccyx, they unite. Okay, so they are not on either side. So the either sides come and unite and form only one ganglion. Or it is called as a ganglion implant or ganglion of Walther. Okay, these are the two names which are given to that. Now, anatomically, there are many, I will say, anatomical, what we call it as aberrations. Okay, but if you see the commonest place where it is there is at the coccygeal 2 and 3. So this is the place almost most of the times your ganglion impar is there. So some people say that you come and give a block from here or you come from below and give it here. What we usually perform is that we come through the junction of your sacrum and the coccyx. So the sacrococcygeal joint, transdiscal. There is no disc over here. If you ask me, we can do that. Okay, so I already told you. So these are the 4 or 5 small sacral ganglion. Okay, and they form it. It is also called as ganglion of Walther. Okay, it marks the end of the 2 sympathetic chains, and the location has also been reported from anterior to the sacrococcygeal joint, 1 to 2 inches at the coccyx. The indications are any pain, pelvic region, perineal region. This is the commonest thing. Okay, post-radiation pelvic pain we use in combination with the superior hypogastric plexus. Chronic prostatitis, I don't know. I have no idea. I have not used it. Proctalgia fugax, this is another condition where you can use it. Coccydynia, yes. Endometriosis, yes. I don't know about these presentations. Again, contraindications are same. I added this patient refusal as another contraindication. Equipments, the same thing. If you see the equipment, the needle size is decreased. Okay, you 1.5 inch needle size is enough to perform this. Here you can use phenol very safely. So patient lies in prone position. C-arm is AP lateral. So this is the AP spread. This is the lateral spread. Okay. It's not very clearly seen. So what we do is that here is your ganglion. Okay. So sacrococcygeal junction we usually perform is that. So you puncture through this sacrococcygeal junction. Okay. Just come anterior to it. You see the spread of the dye. You see there's a crescent moon shaped spread. It should be like this. Okay. And there should be a proper dispersion in AP view. So if you have that, that means you have, it's a proper needle placement. Only problem is that it may cause rectal perforation. That's the only thing. Otherwise, it is not. Okay. And this is the technique by which we can perform. And we almost inject up to 8 to 10 ml. So it doesn't matter whether you are coming at the sacrococcygeal junction or you are coming from down, because you are giving almost 8 to 10 ml, the spread is there. Okay. Complication. So this is the commonest thing, complication which I had encountered, perforation of the rectum, nothing else. And there are very small case reports which say that yes, from pelvic and perineal pain due to cancer, if it comes, it has a good role. Okay. And in this study which was done by Plakatia, is there another study by Bhatnagar who have done, as well as Ikar who have done in 2008, and this was in 2012 by Bhatnagar, and they had 16 patients underwent the block, and almost half reported have a complete pain because of this block. Okay. So this is what is a ganglion bar. So I'm open to questions now. If you have any questions, we can take on the questions. Yeah. So just a simple thing about we classify for the anticoagulation things, antithrombotic, antiplatelets. I just thought I will just discuss this. Low risk procedures, intermediate risk procedures, and high risk procedures. So based on this, if you see, our ganglion implant is a very low risk procedure, so there is no need to stop. You can directly perform the block even if the patient is on clopidogrel. But if it is an intermediate risk procedure, like our hypogastric plexus, lumbar sympathetic, and celiac plexus, they are classified as intermediate risk procedures. So yeah, celiac plexus is a high risk procedure, sorry. But hypogastric plexus is an intermediate risk procedure. So based on that, this is the classification. This table I will share with you. Okay, and you can just read it, or else in your pain clinic, you just fix it and you know what to do, because it is a very table which is very difficult to remember, because these are the guidelines given by American Society of Interventional Pain Practice and American Society of Regional Anesthesia. So they vary slightly. Okay, but based on that, you can classify it. Okay, so low dose is aspirin, ASIPP. So we follow ASIPP for our blocks. This is for regional anesthesia. So you say that they continue or may stop for 3 days. Okay. Clopidogrel may continue. So that is what they say. Apixaban, most of the patients, our patients are on low molecular weight heparins. You discontinue for 24 hours. And after the block, after 12 hours, you can start it. This is what it is. All right, I'm open to questions now. Any questions? Or anyway, I think you all guys are coming to Bangalore, right? And we can meet in person and we can discuss in more details, and we can chat and we can discuss many things. No problem. Right? You're always there to help you guys. And I think I made it very clear these things so that you come with a prepared mind the next weekend. Okay, and you can very well understand. All right, so we call it a day.
Yes, sir.
Yes, sir.
Yes,
All
sir.
right. Take care. Thank
Yes,
you.
sir.
Thank you, sir.
Thank you, sir.
Thank you.